good afternoon, all, and maybe, good evening, all, in some region of the world. It's my great privilege to invite you all for this today's webinar on adult spine deformity. And we have galaxies of stars, which is going to share their experience across the world. It's my great privilege to introduce Professor Kwan, one of the Asia's region's most distinguished spine surgeon when it comes to deformities. He serves as senior orthopedic consultant in spine surgery at University of Malaya and is internationally recognized for his expertise in deformity. Professor Kwan is immediate past president of Asia Pacific Spine Society and a past president of Malaysia Spine Society. Beyond his outstanding clinical practice, he has made significant contribution to spine education research and the advancement of spine care across the region and the world. It is an honor to hand over the proceedings to Professor Kwan. Professor Kwan, please join us as the chairman of the program. Over to you, Professor Kwan.
Thank you, Niraj. Thank you for your kind introduction. I would like to welcome everyone here to the APSS online educational webinars. I'd like to welcome the president of APSS who are watching the webinars, the ESCO members, the speakers, the moderators, as well as all the participants who are attending these webinars. Welcome again. So this will be the fourth APSS online webinar. The title of the webinar today is Adult Spinal Deformity. So these webinars have gathered a lot of viewers. Every webinar usually will strike approximately about more than 2,000 views in 2 months. So I'm very sure that this topic on adult spinal deformity will also gather a lot of attention. I would like to take this opportunity to thank the Online Education Committee under the Educational Committee of APSS have taken a great effort to organize these webinars. So today, we have invited many great speakers, Professor Franke from Germany, Professor Neel Anand from the United States, and also 4 other prominent speakers from the Asia Pacific region, Dr. Ranjith Unnikrishnan, Professor Huiren, Professor Liu Kim, and Dr. Amit Jhala from India. So without further ado, I would like to pass over this session to our 3 moderators, Ajoy Shetty, Dr. Yuda, and Dr. Ali. Thank you.
Welcome you all. Before you go on to the program, we would like to show the video of the upcoming events of the APSS. Can you place the recording, please? I welcome you all again. On behalf of myself, Dr. Ajay Shetty, along with my co-moderators, Dr. Mohammad Aliya and Yuda Mohan Shakti, we invite you all for this webinar, an interesting webinar on adult spinal deformity. I mean, we all know that adult spinal deformity an X-ray probably raises more questions than answers. And we have a galaxy of stars who are going to bring about their experience and try to answer some of the questions we do have regarding the management of adult spinal deformity. Without wasting much time, I would like to invite Dr. Ranjith Unnikrishnan to deliver his talk. Over to you, Ranjith.
Good afternoon. Can you hear me?
Yes.
I'm okay, sir. Thank you very much, Dr. Ajay, Dr. Neeraj, and the entire APSS team. Glad to be here with a galaxy of speakers. Go to my slide. Okay, so I hope you're seeing my screen full screen. Are you seeing my screen full screen, sir?
Yes, Dr. Ranjith, everything is good.
Yeah, thank you. So typically when we face this kind of deformities in adults, and when you end up with these different results, there should be some method to madness as to how we reach there. And there should be some logic to the reason. Like Dr. Shetty said, right now, there are more questions than answers. Is there a way we can come to some solution and have a game plan? So this is the primum thing whenever you have another deformity. It is pain and disability which determines the treatment and not the deformity per se. So it's very complex and very, at the same time, confusing. So how do we decide? Let us, in the next couple of slides, let us try and see how we can do a plan with respect to the current evidence. Another deformity is a place where there's maximum amount of long-term data coming in and granular data, which is driving your decision-making skills. So whenever we face a deformity in the adult, we should answer this 4 questions. Try to understand, how do we classify this coronal and sagittal deformity with respect to the normal for that patient, not just the age, it is for that particular patient. Next, what we should know is that how much correction is needed and how do we reach those alignment targets? If you have to decide for a fusion, how do we decide which is the UIV and what is the LIV? And if we ever have to use osteotomy, what do we consider? And once we have achieved all this, how do we protect what we have done and protect him from getting a PJK or a malalignment? So at the outset, this is primum non nocere. Frailty index is very paramount whenever you plan any adult deformity. As important is bone health, sarcopenia, and mental health. So I am proceeding, understanding that this primary prerequisites for any adult deformity surgery is met. We should not proceed further unless these things are met primarily. Now, 68% of them have got some kind of deformity on imaging. 40% of people with adult deformity with a surgery may develop a PJK or a PJF. I will not dwell further because we have a dedicated talk by Dr. Jhala on this. And approximately 9.7 to 10% reoperation rates even after carefully selected patients. So what are the questions? Long fusions are effective, but they are prohibited for high mechanical failure and consistent. Curve magnitude alone is rarely an indication for surgery in adult scoliosis. It is symptoms and functional impact. Next, most important point is that coronal correction magnitude does not reliably correlate with pain relief. So the surgeon's task is matching the right amount of surgery to the right patient, not the largest correction. So we all are familiar with all these classifications and lenses. We have the Rosoli who described the natural sagittal morphotypes, and mind you, he told more about the compensation patterns. He did not tell about the correction needed. Schwab kind of standardized it with respect to the PT, SV, and PI minus LL. Gap score gave us some kind of custom-made solution, and T4 to L1 hip axis or the TEA axis is a very reliable intra-op measurable modality. Have they all given us a solution? So these are the 3 parameters which are anchored to every surgical plan when we see. This is data from 2025. Look at the C7 surgical vertical axis. Look at the T1 pelvic angle and the global tilt angle. So this together gives us what correction we need, what compensation is the action, and how much should we correct. Now, how do we all grew up listening this PI minus LL is sacrosanct. Today we know from the publication by Muro et al. That it is highly variable. If you look at the data, it is normative. The formula is now PI minus LL is equal to minus 28.5 plus 0.44 in the pelvic incidence. This is custom made to the particular patient. This data as early as late of 2022. And the mismatch is zero only when the PI is 64. Now we know that a fixed PI minus LL less than 10 degree either overcorrects a low PA patient or undercorrects a high PA patient. So we have to dial in the right for that patient with this particular formula. This is enough evidence to support that. And whenever we reach the alignment target, you should, in practice, never go by one of those classifications. You run all the four checks and you have to see at least one or two modalities and take the best of it to decide where you will decide your correction. I'll not get into great detail for want of time. Now, this is one very important data from Lafayette. A 10-degree change in lordosis produces very different global effects depending upon where is it made. So if you make it at L4 to S1 or L1 to L4 or a thoracolumbar junction, we know that there is a significant change in the sagittal balance up to where it is made. So the practice tip is that today we need to have the maximum lordosis correction at L4 to S1. So that is a workhorse. We know the load LDI, the lordosis distribution index, which tells that this is where we have to have the maximum correction. So all your effort should be looking into that point. The next question, how do we decide the LIV? Does every curve need a T10 to pelvis? So you should ask these three questions before you start your correction. Is the patient actually unbalanced? What are the compensation mechanism in action? What is the real pain generator? The clue is that if the pain is relieved in supine and worse at upright, it means a pain because of loading, and this patient might need some kind of fusion procedure. Is the source focal and treatable, or is it global? Is it a radiculopathy or a foraminal stenosis which is trying to cause this problem? In that case, you can avoid a huge surgery. If balanced with a clear focal pain generator, consider a limited or a focal solution. If unbalanced or the fractal curve is degenerated, then you might have to go to the pelvis when indicated. Which are the patients where we can just do a decompression alone? So these are patients where with less than 20-degree coronal curve angle, when the back pain passes less than 8, when their lower pelvic tilt, their PI minus LL mismatch is 0 or less than minus 10, when you have preserved facets on the approach side. So you, whichever technique of decompression you might choose, the endoscope, microscope, or tube, or whatever, if you can preserve the facets at the side and there is no mobile listhesis. These are the patients in which, when carefully selected, a decompression alone suffices in spite of having a scoliosis. Look at the ODI improvement rate and look at the patient satisfaction rate. 71%. This is from a recent meta-analysis as late as 2022. Enough evidence to support that. When you decide for a long fusion, how do you decide the upper instrument vertebra? If you look at the data from Jörg et al., again, analysis of a large surgeon series, which decided that if you have a proximal thoracic kyphosis or a proximal thoracic column deformity, it's better to go to T3 or T2. Lower thoracic is possible when you have you don't have a structural proximal thoracic kyphosis or a very mobile thoracic spine, but always avoid T6 to T8 because that's a thoracic apex. And if you look at it, you look at the level, the incidence of doing of having a PJK when you don't follow this algorithm. There is high incidence of up to 76%, that is 38% in this surgeon series when you chose the appropriate UIV. Now, how do you choose the LIV? The data from Sardar from 2025 or recent paper. In scoliotic deformity, you can look at the Lenke levels, even though it was described for idiopathic scoliosis. But when you have a hyperkyphotic deformity, The UEV is a suitable UIV as per the prior classification, and the LIV is the first sagittal stable vertebra or the first lordotic vertebra. You might decide to go to the pelvis if you are doing a more level fusion. If you are doing a L3 to L5 three-column osteotomy, the patient is severely osteoporotic. And if you have a significant degeneration or stenosis at L5S1, this is enough data that this lets you have a stable LIV. Now, there is argument as to MIS versus open. If you look at these data from JNS in 2026, the increasing age was a primary divider towards MIS, increasing deformity severity and need for reoperation to drive the decision to do MIS or open. So it should be a deformity-driven decision, not a surgeon choice in these patients. Well, you need to have a plan for this. So the MISTEP the MISTEP 1 published in 2014 and revised in 2018, has given us a fairly good reproducible framework as to which are the patients who should go in for a open surgery and which are the patients who should go in for a minimally invasive or a hybrid procedure. So again, this puts upon the SVA, the pelvic tilt, and the PA minus LL mismatch, as well as the rigidity or the flexibility of the deformity. You're all familiar with this kind of osteotomies. I will not dwell into details. So Schwab told us which are the grades of osteotomies. A fair amount of our deformities can be corrected by grade 3 or grade 4. Rarely, if you have to go to grade 6, which has been open surgery, not a MIS surgery. Again, if you look at the incidence of three-column osteotomies, this was a review article from Larry Lenke published in 2023, which looked at his series of VCRs. If you see, there's a steady decrease in the incidence of VCRs, and as the late part of 2015, 2017, it decreased the amount of VCRs. The PCS was the same. Again, you see in the last couple of years, there's an increase in VCR because now we know about the role of multi-rod techniques, etc., in which the rigidity of the column is maintained and we're getting better correction. So this is again a change in the pattern of osteotomy. Now, this is a classic paper from Obaid, who actually gave us a method as to how do we decide regarding the correctability to avoid a coronal malalignment. We all know that once we ever have to go to the pelvis and you leave the patient post-operatively misaligned, is extremely unhappy. He'll be happy living with a coronal preoperative malalignment, provided you fix the pelvis mobile. But if you go and fix the pelvis and you leave a malalignment, absolutely it's a disaster. The patient is very unhappy. So this is a very good paper which respects about the concave coronal malalignment versus convex coronal malalignment. I'll not go into great detail because of want of time. So just to remember, the gist is that when you have a concave coronal malalignment, you have to correct at the apex of the main curve. If it is a convex coronal malalignment, you have to correct at the lumbosacral junction, depending upon the mobility of the lumbosacral junction. So the simple thumb rule is that look at the T1 plumb line on standing films and then follow the curve direction into the tree. This gives us which is the main curve. Now look at the compensatory lumbosacral curve, determines its flexibility or the presence of stenosis and decide your pelvic fixation. PJK, we know that it's been fairly documented now. Even Yagi has given a very reproducible classification. I will not go into the details because we have a next talk dedicated to this completely. So what is the integrated decision pathway? Number one, classify the deformity as per your choice, Rosolis or gap. Next, set individualized target. Don't look at the global PI and then look at that PI and LL mismatch calculated as per the pelvic incidence for that particular patient. Next, decide the extent of fusion. Should it be a focal or a global, long or short? Next, select your UIV and LIV plus or minus pelvic fixation based on the guidelines described. Next, choose the approach. Look, run the MISDEF2 algorithm. See, is it feasible for MIS versus open? Because we have enough evidence today convincing that MIS has got decreased morbidity, decreased blood loss. So if it's possible in your setup and your hands, next, decide the extent or kind of osteotomy as to what you have to do. And once you decide, take everything and anything possible to mitigate a PJK or a coronal malalignment. Kindly note that this is a loop, not a line. So you might have to dial in your intra findings, bone quality, flexibility, and have to revise your plan based on the prior decision. So to conclude, alignment targets must be individualized by pelvic incidence, age, and the patient's own compensatory mechanism, not by a universal number. Curve magnitude is not an operative indication. Match the extent of surgery to decompression alone to focal to long fusion as per the pain generator and balance of the patient. L4 to S1 low doses correction has the greatest leverage on global alignment. Plan level specific correction, not just total LL number, because we know we have to respect the LDI. UIY and LIV selection follows regional kyphosis and curve rules. Deviating from if you deviate from those plans, be prepared to have an increased incidence of PJK. MIS is chosen more by patient factors than by surgeon preference. It should be open surgery is driven by deformity severity and need for decompression. Coronal malalignment direction, concave versus convex, dictates where the correction should be targeted. The paper by Omid et al. Is a real eye opener. I urge all of you, the listeners, to go and read it up because it needs repeated reading to understand. PJK prevention is multimodal. Alignment target, UIV selection, soft tissue preservation, and bone health optimization all matter to them. Thank you very much and open to any questions.
Thank you, Ranjith, for a very interesting talk. You said that the lower lumbar fixations and the lordosis is more important. What type of fusion you would prefer at the L5S1, especially in the cases which go into the pelvis? Whether you prefer an ILIF?
So for me at L5S1, since if I am planning a open surgery, it will be a L5S1 T-lift with S2I fixation with quad rods. If I am planning an MIS surgery, it will be an A-lift at L5S1 with O-lift at the other levels.
Any other questions from the other speakers or the moderators?
Professor Kwan is raising her hands, Dr. Shetty. Yes, Professor Kwan.
Yes, sir.
Yes, Ranjith.
Yeah.
How do you dial the L4S1? Let's say you're doing the surgery from L2 to pelvis. You mentioned the importance of L4 and S1. I totally agree with your in your presentation. How do you clinically, all right, dial the L4 and S1?
You mean how do I measure intra?
Yes, right.
Yes.
How do you decide how much to aim for intraoperatively and how do you measure it? Because this parameter is so crucial.
Yeah. So I take my decision based upon whole spine standing, AP, lateral, bending, and supine AP. Supine AP gives me a lot of information about the lumbosacral junction with respect to flexibility because the patient is pain-free, unloaded, it opens up. And once I decide my levels, what my preoperative target, I do my intraop measurements. I measure the segmental low doses and L4 TPA, L1 TPA. So a lot of my decision is based on L1 TPA. I do my L1 TPA, measure intraop with the cognitive with the smartphone app, and I try to create that back as to what I wanted. If I do it, I don't get it, I repeat, I release my rods, again do a more facet resection at a more level. And if that is not possible, I'll do a disc bone osteotomy. I go and wedge out a part of the input of L4 and low dose more. So whatever I achieve, and a lot of it comes from supine AP X-rays. Because if you take a standing AP in a degenerated spine, it is useless because patient has pain, they will not bend. A supine AP has changed my perspective quite a lot.
Thank you very much.
Neeraj?
Ranjit, excellent talk as usual. One thing, There are two school of thoughts when it comes to deformity correction. If you specifically think about MIS or open, there are some surgeons who want to contour road and reduce the deformity on the road. And there are surgeons who want to do intradiscal work, put different kind of cages, respect not only LDI but inflection points, according to Rosales classification. What is your opinion about it?
So for me, deformity surgery is not created by rods, it is by releases. It's by releases. So I significantly believe in releases to get my deformity corrected, number one. So the cages are my pivots to do my correction. Pivots do my correction. And if I don't achieve something with what I release, putting a cage will not help me. I have to release more. So my cage positions exactly, and I don't want to load my rods too much because they are weak points for me. That's why in a three-column osteotomy, I never ever do today any three-column osteotomy without having 4 quad rods across it. Because I've had 10, 12 year later failures of ECRs when I don't have 4 rods across it. So it is not by forceful correction. I will not say that you should not apply force, but it is your releases, your ALL release, anterior release, facet release. All these combined together should decide your correction.
Thank you.
Thank you, Ranjith. Because of want of time, we'll move on to the next speakers.
Thank you.
We will have the video played of Professor Huiren Toy, and I would request Yuda to take over the moderation.
Thank you very much, Professor Jörg. We go to our next speakers, a really renowned speakers. I also study from him, Professor Huiren Tao from Shenzhen. Please, the time is yours, Professor. Nice to meet you again, sir.
Thank you, Dato. Please play my video. Cigarette. Good afternoon, everyone. I'm Dr. Tao Huiren from China. My topic is how I treat complex kyphotic deformity. Patients with ankylosing spondylitis often develop kyphosis at its advanced stage. Severe kyphosis significantly compromises patients' daily life. They cannot lift their heads to see straight ahead or lie supine, often resulting to lying on their side or even sitting while sleeping. Mobility is also markedly reduced, compromising both independence and quality of life. Our surgical goals are to restore sagittal balance, to prevent deformity progression, and to improve quality of life. Anyway, when we correct the kyphosis, we will face many challenges, such as difficult surgical planning, difficult airway management under anesthesia, difficulty positioning the patient, and so on. I will present several techniques for addressing these challenges. This 36-year-old male patient has suffered from progressive worsening kyphosis for 9 years. Before surgery, we used the SurgeryMap to simulate kyphosis correction. We ran 2 virtual scenarios, a single-level PSO and a 2-level PSO, and compared the predicted sagittal alignment outcomes. It appears that the 2-level osteotomy provided better sagittal balance, and therefore we adopted the protocol for this patient. We used a Marquis bed. The bed was flexed into the jackknife position. The patient was positioned in prone flexion over the bed. Pads were placed under the thoracic region and thighs to avoid pressure on the abdominal region. Traditional PSO removes entire pedicles, leaving at least one disc intact, but missing posterior elements, causing instability. Our modifiable PSO resects only the superior part of the pedicle, preserving the inferior part of the pedicle and the articular process. First, we performed a laminectomy. When the laminectomy was exposed, they appeared obviously into a single burning mass. The interlaminar space could not be identified due to calcification of the ligamentum flavor. We used a high-speed burr to create a small gap Afterward, the lamina was removed with kerosene. The articular process was resected to open the intervertebral foramen. Next, we resected the superior half of the pedicle and vertebral body. Bipolar was used to carefully control the bleeding. Then an ultrasonic scalpel and osteotomy was used to fragment the pedicle, which was subsequently removed with a Petri roundel. Bone wax and other hemostatic agents were used to control bleeding. Use Petri and curette, the caseless bone was removed. A temporary rod was applied to prevent subluxation. A similar procedure was performed on the contralateral side. After laminectomy, the articular process and the T12 rib head were removed to open the intervertebral foramen and expose the lateral side of the T12 pedicle. Bleeding was carefully controlled, and the pedicle was fragmented. Finally, the pedicle and vertebral body bone were removed with the Petri roundel and curette. Using a curved osteotomy, the anterior wall of the spinal canal was removed and the dura sac. Another temporary rod was applied. When correcting kyphosis, it is impossible to achieve correction using the internal fixation system alone. Off the table, the circulating nurse and the other staffs lifted the patient's shoulders, while the surgeon performed the in situ rod bending on the table. First, alternating compression gradually closed the gap. While the patient's upper body was lifted, the surgeon performed the in situ rod bending on the table. This correction cycle was repeated until satisfactory correction was achieved. Finally, the temporary rod was sequentially replaced with the final rod. Bone graft and a cage were placed into the gap. Compression was applied, and a final tightening was performed. During gap closure, repeated compression was applied to the screw near the osteotomy gap. In severe osteoporosis, the screw tends to cut out. The application of the double-headed connector helps avoid such cutout complications. Two short rods were used to connect the screws separately on each side of the gap. Then a third rod was connected across the two rods using double-headed connectors. During compression, the force was applied to the two short rods and then to the screws, rather than to only one screw near the gap. After assembly, the two short rod and double-headed connector complexes were installed onto the screws on each side of the osteotomy. A third rod was connected across the two complexes, spanning the osteotomy gap. Alternating bilateral compression was applied to close the osteotomy gap. While the patient's upper body was lifted, the third rod was bent in situ on the table to achieve satisfactory correction. In severe kyphotic deformity, single-level osteotomy is insufficient to achieve satisfactory correction, often need a two-level correction. However, during the second osteotomy, maintaining stability of the first osteotomy's instrument construct to prevent subluxation remains a significant challenge. We use a double-headed connector and a temporary rod to link the first level construct to the second level, enabling it to function as a single stable unit and prevent loosening of the entire instrumentation construct. We use a temporary rod to connect the distal screws to the proximal double-headed connector, which links to the first level of construct. Alternating bilateral compression is used to close the second gap. While the patient's upper body was lifted, kyphosis was corrected on the table by bending the rod in situ. Then the final rod is sequentially changed. This is the clinical appearance. The patient got a good alignment. So using surgery method to simulate correction, position the patient carefully, correct the kyphosis manually with the assistance of the table. Use a double head connector to prevent screw cutout and to facilitate two-level osteotomy. Thank you for your attention.
Thank you very much, Professor Tao. I think we can call upon questions from the speakers and other faculty. If there's any questions from the faculty. Or not, maybe I can start, Professor Tao. Usually, ankylosing spondylitis also come with the hip problem, hip stiffness. Can you tell us your preference, whether you're going to the hip first or you go to the spine, sir? Maybe the algorithm.
That's very good question. At my early practice, I was told that if you do the hip first, the hip will dislocate and you will meet a lot of problem. But at first, at my early practice, I also to correct the spinal kyphosis first, then hip treat hip. But to those patients, when you correct the kyphosis, because the hip is stiff, the whole body is stiff, the patient will experience difficulty to getting up, to sleep, very difficult. So I cooperated with experienced joint surgeon. He said, okay, no problem. I can do the hip first and no dislocation. I believe him. So we do the hip first right now. Yeah, no dislocation until now, maybe already 20 to 30 cases, no dislocation. So nowadays we do the hip first.
Okay, thank you. I think we have a question from Professor Frank from German. Please, Professor.
Yeah, thank you for your excellent talk. Actually, I liked a lot that you mentioned that you can't only correct over the rods, that you have to lift up the shoulders in order to kind of get the pressure out of the anterior column, because I think this is totally important. And I would like to commend you on this a little more on the fact, how to prevent the anterior shortening while compressing. So maybe, I saw you always have two screws in the rod construct in order to make it rather a rotation before rather only a compression. Can you please comment on that a little more?
No, in fact, the first I will compress a little, compress first, then I lift the upper body and do the in situ bending. Not the in situ bending first, because when you do the in situ bending, the spinal cord, in fact, spinal cord is distract, so it will increase the tension of the spinal cord. So we should compress first to
Yeah,
shorten the spinal cord, then in
yeah,
situ
but
bending.
what about, have you ever experienced kind of that you not really had a wedge, that you rather, made it a flat vertebra by when you compress, right?
Yes.
Not rotate, it might shorten the anterior column. So therefore, I think lifting up the shoulders and
Yes.
including above and below more than one screw for the compression procedure, it decreases the risk of losing height in the front by doing the correction. Is that right?
Yeah.
I couldn't understand your question. Could you repeat it again?
My question is how to avoid,
Mm,
while doing the correction, to kind of lose the height in the front, right? How to take off the pressure on the front, right? In order to produce a flat vertebra instead of getting a nice correction.
Dr. Yoda, can you explain it
Yeah.
again to
So
me? Mm.
how do you prevent the failure of the front when you are doing the correction, so it will
Yes.
not fail? And then on the anterior part, sir, how do you really control that correction, Professor Tao?
Prevent a correction.
Failure in the front, sir. So when you are doing the
Failure of the
correction,
plant.
yeah,
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 failure of the plant. In fact,
in
several
the
way.
anterior.
Yeah, several way, because we lift the upper body, so the plant, I think the force of the plant decreased. Yeah. The second way, I use the double head connector, so the force spread into the usually for 2 or 3 screws, so to prevent the cut out, the screw cut.
Okay, so
Uh,
yeah, no other miracle, right?
yes,
Mm.
Professor. Just last quick question, Professor Tao. What is your average bleeding? Average bleeding for the correction? There's a question in the chat from our user.
It's quite different. Some patient maybe only 300 to 500 milliliter, but some patient I experience 2000 millimeter. But nowadays, usually, I think 500 milliliter. Mm.
Thank you very much, Professor Tao. Again, because of the time, I give thank you very much, Professor Tao. I give the time back to the main moderator, Professor Ajay Sethi. The time is yours, Professor.
Thank you, Yuda. I think we'll invite the next speaker, Professor Franke, to deliver his talk on the SI joint fusion or not in adult spinal deformity surgery. Over to you, Dr. Franke.
Yeah, thank you very much, and thank you very much for the invitation. I'm very happy to be together with my Asian friends again. So that's fine. And actually, I was asked to talk a little bit about the lumbosacral area, and maybe what to do about with the long fusion to the pelvis. As we all know, there are quite a few problems. And actually, I talk about the SILVIA study with the bedrock device, with a triangular device, I try to convince you a little bit that maybe an additional fusion might be a good idea with the results from the study. Well, that's me. Those are my disclosures. And you actually see, this is pretty impressive, this kind of contributing centers to the study. And, I'm pretty proud that, this little one here, this is the only German site in a big mix of the big US centers in the study. So we were very happy to be part of that. And coming back, first to is it an issue? Lumbosacral region, is that solved by ilium screws and S2ala screws? Probably not. I mean, we have, Neel Anand here, who reported on that with a rather low problem, kind of percentage problem, and some other ones reported a rather high percentage of problems. And actually, from 14 studies, which Dave Polly, the study initiator and main investigator, made earlier on, that the overall failure rate of the lumbosacral instrumentation is 17.2%, which is high. So obviously, we have a problem in the SI joint or in the lumbosacral region by doing a fixation for adult spinal deformity into that region. And there's another one, there's kind of as acute as one ala ilium failure in a study with more than 3 levels fused and S2 ala screws. And the failure was here in that study observed in 5% only, but there's a lot of failure modes. There's slippage of the rod, there's displacement of the set screw, there's kyphotic fracture on the sacrum. So actually, and that failure rate is across all implant manufacturers. So it's not related to a specific kind of implant from one company. So it's kind of an overall phenomenon throughout, all manufacturers. There are some examples here with a set plug dislodgement. You can see on the right, then there is set plug dislodgement with a sacral fracture. And I'm pretty sure everyone who does a lot of deformity surgery, knows those problems. And in addition, there are sacral fractures, there are screw loosenings, there are quite a few mechanisms of failure in that region. As to other screws, there's an analysis, another one from Asia here, published in the operative neurosurgery. And you see there's, again, loosening of the screws, there's set screw dislodgement, neck fracture, shaft fracture, revision and needed. And there's another phenomenon which shouldn't be underestimated, which is SI joint pain, which is sometimes present up front before the surgery for the kind of sagittal malalignment and osteoarthritis in the joint and so on. But there's also new pain occurring after the surgery. So that's another problem besides the mechanical failure. And you see here on the left a few kind of shaft fracture, then you have screw loosening on the A picture here, and you have some fracture over the joint. So there are a lot of problems occurring with that instrumentation. And this is kind of a effect study in revision surgery in adult spinal deformity. It's a multi-center study. There were quite a few, almost 900 patients reviewed. 350 met the inclusion criteria. And you see the rate of mechanical problems is rather high with over 30%. The infection rate is rather high. This is probably not due to the instrumentation to the ilium. However, it's rather the kind of the long surgery, the big wound, and maybe the time of the surgery. There are wound problems, and again, we should not forget the SI joint pain within that population instrumented to the pelvis. So there's room for improvement, obviously. So actually, we have to look, and we learned already from the first two talks, pelvic fixation is rather a difficult surgery with needed a good planning, but it remains unclear how to do and how to perform the pelvic fixation. Is it S2 screws? They have loosening, they have implant breakage. It's associated with new onset of SI joint pain. So actually, we have to have a close look at the fixation of the SI joint and maybe do a little more than just putting a screw over it. So the objective, and you can see it here, the two pictures, the one above is just a simple S2 screw, and the one below is an S2 screw in conjunction with a bedrock device, a triangular titanium device, and a fusion device for the SI joint, just in the same setting as you do your deformity correction. That's the objective of the SILVIA study. So the implant is an iFuse, so called Bedrock, and that is kind of what we kind of do. And the indication is obviously you can do it for the SI joint fixation with or without a adult spinal deformity surgery. The clinical trial design, pretty simple, is a prospective multicenter international. So the international one is me, randomized controlled trial. The enrollment was 222 patients in 29 sites. It's a four plus level surgery with a pelvic fixation using S2 screws. And the randomization was 1-to-1 from a simple S2 screw to a S2 screw with a triangular bedrock device in conjunction. And we did the usual follow-up up to 24 months with radiographs and clinical results. Actually, the inclusion criterion was to have a over 4 on the VAS score pain in the SI joint, and 3 out of 5 examination maneuvers had to be positive, proceeded to a diagnostic injection. And that was important too. The blinded study coordinator conducted the visit. So it was independent of the surgeon, right? If the patient is eligible for the study. The study endpoint, clinical, was new onset SI joint pain at 2 years, and the change in SI joint pain from baseline in those who had SI joint pain at baseline. The radiographic endpoint was S2 screw breakage, loosening, pull out, and rod breakage distal to S1. So there were the 2 major endpoints of the study in a 1-to-1 randomization. Those are the enrollment data. I know that slide is a little too full, but actually the main message from that picture is both groups were essentially the same. There was no difference between there was no bias in the randomization process. So we had, the same number of smokers and non-smokers and the same length of fusions in both groups. So previously we reported some results that 16% of the subject had a history and were diagnosed for SI joint dysfunction or pain. And actually, that was one of the major points, as some of the sites had not much training before for the TTI, and the placement was successful in 98% of the patients. Actually, that was my concern in the beginning as well. Putting an S2 screw and a rather big device above it, but that's easy. I have to say it's rather easy if you do it with navigation anyhow, but even if you have only radiography, and the fluoro, you can do it with a teardrop view pretty nicely to put both the screw and the fusion device above. That's not a miracle. It's not rocket science. So those are the results, and they are pretty impressive. Given the fact that the group of patients we treated is rather heterogeneous. So it was from T3 to ilium fusion, and maybe sometimes only an L2 to the ilium fusion. And still, we saw that the primary endpoint showed 8.5% new onset pain in the SI joint in the S2 group alone versus only 1% in the additional or in the Verum group, the fusion group. So that is a pretty clear result that we could do something about the new onset of SI joint pain by using the fusion device in addition. So this is the change in the SI joint pain. And here, even though not significant, you see the 0.08, maybe with a few more patients, we could have reached even significance here, but still the improvement is higher in the fusion group versus the S2 screw group alone. So that's very interesting too, even though not significant. Secondary endpoint, and actually that's given too maybe due to the fact of the heterogeneity of the groups, the ODI improvement was kind of good and no difference in both groups. They had a significant improvement from the adult deformity surgery, and which was 20 points on the ODI. And the pelvic revision rate was also similar by both groups, 7.1 versus 7.3%. So they had a little, the S2-ALA group had a little higher incidence of S2-ALA complications, which, is listed here, but it wasn't significant. Limitations, what I said already, there was a heterogeneous group of patient. There was an initial learning in the placement of the bedrock device. Some had done less than 3 cases. And there was also a great variability of the technique used. It was freehand, fluoro, navigation, robot, and therefore there was quite a bit of a variability in length of the bedrock TTI device. And there was a variability of the size of the S2-ALA screws as well. Even though, don't forget, there was a significant reduction in new onset of SI joint pain by using the additional fusion device. And the conclusion, therefore, is pretty simple. So the incidence of new onset SI joint pain was within expectations of former studies. It's a little unclear, so how the long-term results in the follow-up will be, but the additional placement of a bedrock triangular device in addition to the S2-ALA screws reduced the incidence of SI joint pain in the follow-up. It reduced the SI to ALA tulip failures, and it reduced the S2-ALA lucency rate quite a bit, which is not statistically significant. Maybe it's due to the fact of the study size, but the concomitant placement of the TTI parallel to the S2-ALA screw during multi-level spine surgery is feasible, safe, and it's coming with a little bit of an advantage to our patients without, have a trade-in with much more complications. That's the results from the SILVIA study. More to come. We recently published, the radiographic results in the Journal of Bone Joint Surgery, which is open, so you can download it from the journal. Thank you very much.
Thank you,
Yeah,
Dr.
thank
Franke,
you
for
very
an
much.
excellent talk. Yeah. Was there a variability in the study group with regards to L5S1 type of fusion?
No, it wasn't. So it was free. It was to the discretion of the surgeon. If we, it was A-lift, T-lift, no anterior support in the group. So there was very heterogeneous, everything in it.
Okay. Any other questions from the... Yes, Neeraj?
Professor Franke, excellent talk. I know you said that long-term result is still awaited, but traditionally when we started discussing about PJK, it said that when you go to S2AI, PJK rate went up. Now we are going further downwards. What is the preliminary post hoc or maybe subgroup analysis of, is there any impact on PJKs when you actually fuse this SI joint straight away from day one?
Actually, Neeraj, I raised the question, within the study board, and it's very, very difficult to answer. That's due to the fact that we included 4-level fusions and more. So there are a subgroup analysis within, because we have quite a few, kind of to L2, we have a few to T3. So actually, we, with the company, we will have a look at it, but unfortunately, I fear that we won't get a really very, very good results from that due to the heterogeneity of the study group. So, but maybe a few hints are there because me too, it's some concern that maybe having a stronger fusion in lower down that it may increases the stress above a little bit. But I see Neel may have the answer for us.
I don't think
Neel.
so. I don't think so. But thank you. It was a great talk. My question was more to the point that I think the issue is, should we prophylactically fix the SI joint on day one as opposed to doing it later? And I'll tell you why. Well, Larry and I, both of us have done deformity for years. If SI joint was such a problem, they should be falling off the trees. Forget me. Look at Larry, how many cases he's done, right? You should have a tremendous amount of SI joint problems if that were truly the case. I believe it exists. I believe it does. Maybe 5 to 10%. Maybe we're missing a few. But the question is, should we prophylactically on day one do it or not? And that I think is the bigger controversy, right? And I think people like me would wait. We'll do it and see, okay, if it comes back. I'll agree. I probably do about, I'd say 3 to maybe 5 a year. I'd say 3. And they come back much later. So I'd rather sit on that than do it later. That's all. I think that's the argument that I see here. Beyond the rest of it, I understand.
But
makes
then,
sense.
Neel, may I come with the question? Shall
Please.
we do staged surgery and maybe stop at L5? With our primary correction and wait how they do. If we found the right balance, maybe they get away with less problems down below and do it later and add it on to the pelvis. So that's probably a little advanced towards what you said, but maybe we should think about it, right?
No. I completely agree. Like for me, absolutely, I will say 5-1 if the 5-1 disc is good. But the disc is bad, tilted, trashed. There's stenosis there. You got to deal with it. And the other issue is, I think when you grab the pelvis, you get much better coronal and sagittal correction. It's something about grabbing that pelvis, the iliac screw. You get a much better global correction. And so I have no hesitation going to the pelvis in getting a good global sagittal correction. But I think if 5-1's good, oh, hell, I will not do 5-1. Absolutely. I've got many patients. I will not do 5-1 if 5-1's good. No, we don't need to. I'd rather wait. Give them 5-10 years. They'll come back. It's okay. But they got 5-10 prime years. They're functioning without a pelvic fusion. No question. No question.
I remember our little conversation in Istanbul, where your claim was, kind of PJK was not present before us.
I agree. We created it. It doesn't exist. It's an iatrogenic injury. Agreed.
Thank you, both of you. Because of want of time, we'll move forward. Dr. Franke, thank you for your talk. I'll
Pleasure.
invite Dr. Alia to moderate the next session.
Thank you, Professor Ranjith. The next speaker will be Professor Kim Sung Hook. MIS, the deformity, and we will talk about the role of MIS and the deformed spine. Please, Professor Luke, time is yours.
Can you hear me okay?
Yes, we can hear you.
Hello, everybody. Thank you for kind invitation. Personally, I think the deformity spine surgeons are the real spine surgeons. Let me honest, I do spine surgery, even though I like it, isn't strictly essential. You can actually do pretty much of all those surgery just using the microscope. But deformity surgeons, they are totally irreplaceable, right? So you guys have my kudos. My topic today is the role of MIS and endoscopic in the compensated deformed spine. Let me give you my main message first. In one sentence, the most important skill in deformity surgery is not how to correct. It is knowing which spine does not need to correction. This is my disclosure. And actually, 2 years ago, I was invited to APSS in Hong Kong. And back in 1996, exactly 30 years ago, when the Professor Moon is the second president of the APSS, gave his very last student lecture right before he's retiring. And I was in the final year of the medical school, right? And let me start with a case. 73 years old lady, her stage operation at one of the big private hospital in Korea, and by one of my former fellow, and the vertebral column resection at L1 and long fixation from the T10 down to the L5, laminectomy, and post-operatively day 1 hemiplegia. She was transferred to Seoul St. Mary Hospital to me, and brain infarction, motor grade 0. And during the admission, one more the bad things, deep vein thrombosis happened, and IVC filter inserted in ischemic colitis with infarction. I followed her until 2020, more than 7 years, and she never recovered, wheelchair bound. This is what deformity correction can cause when the complication happen, right? The operation was technically reasonable, very well done. The question is whether she needed at all. And so why do we end up doing these big operations? Look at this pathway. The top row is traditional route, discectomy in the 30s and stenosis operation in the 40s, and then instability comes up. So fuse, then the next segment to break down, and so we fuse again. And at the end of the road, other deformity surgery. Like the patient I just showed you, and the bottom low is endoscope root, endoscope discectomy, over the top decompression, craniotomy, and the idea is simple. At each step, take less, keep the multifidus, keep the ligament, keep the bone, less scar tissue, so the next operation is easier, not harder, right? And this warning is not new. In 1993, James Robertson, the neurosurgery professor in Memphis and the president of both of the CNS and ANS, wrote a paper with a very hard title, right? His point was that we were fusing too much. In 2015, 11 years ago, Richard Nelson used the same title again, and TSA, 22 years later, and almost nothing have changed. So I asked myself in 2026, today, are we going to be next chapter for that same story? Is it one of my the colleagues in the States, he posted when this patient came up the operating clinic, he felt like this. How do you stop the ball rolling down the hill like this? All right. So here's the plan for today. The first, the natural history, these are Scully. The second, the compensated versus uncompensated, and what the evidence actually say now, and the case vignette, and then the main part, endoscope select decompression for the compensated spine, and finally take-home message for you. The first, the 2 words this whole lecture depends on. The compensate means the global balance is still preserved. The patient body has observed the deformity. The curve may look ugly on the film and X-ray, but the spine is still paying for itself. In that spine, the selective decompression can work. Uncompensated means compensation has failed. In that spine, compensation alone will fail because the deformity itself is a problem. not the nerve, not the just nerve. Please keep these two words separate in your mind for the next 15 minutes, right? So now I have the small quiz for you. Here is the 63 years old lady in October 20 years ago, 2006. Look at her x-ray film. Now, the question for you, 5 seconds for you. So can you predict what will happen for her over the next 10 years? What about your opinion? Honestly, I could not. And that is a problem I want to talk about today. So here's what happened to the group of the patient like her after MIS decompression foraminotomy in 2018. I did at the level of 3, 4 and right side, and follow the column, 63 years old, then 74, 75, 76, 77, 78, from 2006 to 2021, right? 1 year, 2 year, and 3 year after surgery instrumentation. The curves kept progressing and decompressed the nerve, and the deformity carried on like this. So now put two facts side by side. Some curves progress after decompress alone, and some curves do not. This one went from 56.8 degree to 58.7 degree over the 8 years between the two x-ray. This is 8 years gap, less than 2 degrees. A big curve compensated, and it stayed that way, same operation, opposite trajectory. So what was the difference? So that brings us to the question I could not answer in that lecture 2 years ago. And actually, I present this kind of the lectures in Brazil 2024. Do we have solid evidence to predict which patient goes which way? Do we have an algorithm to predict the different way of the radiology and clinical outcomes? Luckily, in the last 2 years, that has changed. 4 studies. I have the more than 3, 4 studies. Just notice one thing they have in common. Every single one of them compensated smaller and more than balanced curve, cups angle around 25 degrees, lanky silver grade 1, black dominant pain, and our field has been selecting the compensated spine all along. Different is that today we can say it with the numbers instead of instinct. So how do I decide? How do I decide? These are the threshold, and they are the one side. The radiologic ones are simple. The modest curve, rhodocyte preserved, balanced coronally, no instability at the level I plan to open. But the one I want you to remember is the last one. Left dominant pain does well, back dominant pain does not. Before we go to the cases, one more number about the other sides. This is systematic review of the 29 study, more than 1,200 patients having the deformity surgery. These are good hands and good centers, and this is a risk we are trying to avoid to compensate the patient, right? So let me be fair and show the other side, the uncompensated spine, where the correction really is required. This is my personal the surgical plan when I have the decompensated digital scoli. So this is case a little bit long before 2021, and I operate this patient, rectal inner body 2.5 and only 5%, and the MIS, the instrumentation posterior side. This is the patient a little bit pretty much younger, the 59 stooping, and you can see the loss of lordosis, and the MRI. There's a scanty muscle, and I operate this patient 3-level lateral inner body. I remember it was a pre-psoas approach and only 5SI. And you can see the great restoration of the site alignment, right? The stage of operation and the more than 3 years follow-up. Of course, you can see the little bit the PJK is slowly coming up. This is very successful case. Let me show the unsuccessful case at PJK, and the look at her bone. The T-score is minus 4.5. Very severe osteoporosis and 43 kilograms. She suffered from the severe sarcopenia along with osteoporosis. This is exactly the patient where the big correction is dangerous, but she was truly uncompensated, so she needed one. It was not avoided, cannot be. So when I operate this patient, so PJ came up, and I actually operate her the 3 times, and this is 11 years follow-up so far. One of the very challenging story at the time. And now the main part of the talk, endoscopic selective decompression for the compensated spine. This is the patient I mentioned earlier. Look at the 2 X-rays, 2011 and 2019, over the 8 years. Minimal changes, just the 2, right, neglectable changes of the corpse angle. By 2029, the 2019, she had the knee extension weakness and grade 2, and the intractable pain along the anterior thigh. So the big curve, but a stable compensating one, and the one clear sure root the problem. So by my criteria, that is the good indication with the compression alone, right? Not the corrective surgery. So we did endoscopic decompression for foramen and radialis by the single incisions, navigation guiding, no fusion, no screws. I treated the nerve and left the curve alone, right? So here are the results. Preoperatory 9 months and the 15 months, back pain improved, leg pain, the OSS3 decreased to 2, also improved. Satisfaction rate 60 to 70%. But I want you to hear the patient own words because they were more useful than the scores. Before the surgery, she said she used to be lie down even in the car on the way to the hospital. Now she sits up, she walks about 1 kilometer a day, almost no leg numbness, right? Of course, she had some amount of back discomfort. That's honest. It is exactly what the 5 years data predicted. So second vignette, the 60 years old lady, light dominant leg pain and buttock and anterior thigh, no left leg pain, moderate axial pain. This is Scully with the right foramen and radialis, delivered 3-4. Please note the pattern again, leg dominant one side and 1 or 2 nerve roots from the same level. This is a patient evidence says will do well, right? I used the navigation and did the endoscopic interlaminar for foraminotomy at the level 3-4 on the right through the contralateral approach. Why contralateral? Because from the other side, I can reach out the target under the laminar and open the foramen without taking the facet. On the symptomatic side, I keep the joint, I keep the stability, right? This is the oval floor using this is exactly before the operation plan the corridor and draw the line how much the bone should be resected through the endoscope guidance. You can see the post-op CD. It show the follow the pre-op planning. This is the pre and post-op score. Not only leg pain but also interesting back pain improve a lot. You can see the patient satisfaction is more than 80, reach out to 90% for sure. More importantly, So you are curious about the change of alignment, especially site alignment. Essentially, no unchanged. We did not correct her, and we did not destabilize the patient spine. In a compensated spine, that's exactly the result you want. Nothing dramatic, right? So third vignette and the harder one, the 68-year-old lady who previously had a spondylitis, and she had developed the progressive weakness and pain along the L4 and L5 dermatome. This is a scare the previous infected field, not the beginner's case, right? This is a patient, the whole spine and neck and rattle. So it's right. So I did the bipolar interlaminar contralateral endoscopic foraminotomy. You can see the steps, initial positioning, contralateral sublaminar laminotomy, and the switching the endoscope to the right hand to the reach out of foramen, because I am a right-handed surgeon. So the right switching is a small trick, but it is what lets you finish the foraminotomy safely from the far side, right? So CD on post-op day 2, what did you see now? Right? Well decompressed, the facet joint is preserved, and the almost no trauma to the patient band muscle, right? The third point is the one I care about. Deformed spine, the muscle is a part of the compensation. If I destroy the muscle, then to decompress, I may create the uncompensated spine that I was trying to avoid, right? This is the preserved, the facet and muscle too. And the standing film at the 1-year follow-up, the alignment is maintained. You can actually not only maintain, it's improved. No correction was performed here. The alignment held because we did not take anything that was holding it off, right? So I'm gonna say that when do I not offer endoscopy decompression? So now let me equally clear about when do I not do this. The least matters more than all my good cases. I think they already Dr. Ranjith the presented the when the decompression works very well, right? So this is kind of the things, right? Everybody easily understand. It's not indicated for decompression alone. So where does that leave us? Let me summarize the evidence fairly. The open decompression fusion is still gold standard care. It has the most accumulated evidence for select the effectiveness and safety. If I want to avoid fusion, then stability must be addressed first and preserved. This is a highly polymorphic disease, right? Every patient needs analysis of their own anatomy. In our series, endoscopic foraminotomy gave satisfactory short-term results without sacrificing segmental stability and a patient-specific tailored, I'm going to highlight tailored approach, sometimes transforaminal, interlaminar, sometimes contralateral, ipsilateral approach. Let me build the right plan for the right patient. So this is take-home message. 1, deformity correction is powerful. When it goes long, it goes very long. The risk is the reason for this talk. 2, so the first skill is not the surgical. It is the eye, surgeon's eye, to recognize the spine does not need correction, right? 3, take-home message 3, the minimal invasive lateral inner body for me, for the uncompensated spine where the correction will be required. I understand this. Some surgeons prefer the posterior approach. 4, endoscopic selective decompression for the compensated spine, treat the nerve, leave the curve alone. And 5, we no longer have to guess. Cuffs under about the 25 degrees and lotus preserve, no instability, lack dominant pain. That's your candidate. Get the indication right and everything else follow. That's my message. Thank you for your attention.
Thank you, Professor Huiren, for your presentation. Is there any question from the speaker or from the audience?
So I
One or
have a
two short
question.
questions.
I have a question to Professor Kim. Excellent talk as usual, Professor Kim. I just want to ask one question. That what is your long-term, opinion about compensated but significantly deformed spine uh, and this foraminal decompression? How do you look at 5, 7 years down the line? Do they come back or they remain stable after endoscopic decompression, specifically at multiple levels?
So what I have found so far, usually the cases, ideal cases for selective decompression in the compensated deformed spine. So to find out where the pain area comes, usually it's not the multiple level. So usually it is 1 or 2 levels. So that sort of the decompression selectively, especially with the endoscope, has a significant role to maintain the spine over the time. But as you know, we don't have the long-term data. Majority, even for me, longest follow-up data in the digital scoli is just over the 5 years, but number is not the huge. So we need to make it. But so this is not the end of the treatment. What I mean, the endoscopic decompression cannot be the end of the treatment. Ideally, sometimes we don't know once the patient agree with this kind of the selective decompression, then we can go further with this kind of an endoscopic decompression.
Professor Shetty, can we go on for the next session?
Yeah, Yuda, please do.
Yeah, thank you very much, Professor Luke. The next speaker is the teacher that told us young surgeon fuse, adult surgeon refuses, and then the wise surgeon will refuse. I think we give the Zoom room to our teacher, Professor Neel Anand from US. The time is yours, sir.
Thank you, Yudo. Thank you so much. Listen, fantastic talks. I enjoyed the meeting. Good afternoon, everybody. It's 2 a.m. here in Los Angeles. So good morning. And let me share the screen. Here we go. All right. All right. So my talk is talk of anterior surgeries. That it's a completely different paradigm shift. I'm going to talk of something that I think we need to start thinking about. And it's rather sad that we haven't. Highly conflicted. Every single thing you're going to see, I've either invented, devised, or the technique is mine. So let's take this patient, right? Straightforward, very active, 79-year-old, severe low back pain. To Dr. Kim and Dr. Unnikrishnan's point, I will never fuse somebody without axial, mechanical, low back pain. Even if they got leg pain in the setting of deformity, I'll do a decompression. So that is done. Dr. Kim, I agree with you. There's no need to treat deformity there. You have no back pain. Anyway, this patient has severe back pain, numbness, tingling, tried everything on the surface of the earth, prior PLIF in 98. Obviously, low body weight, BMI. DEXA is bad on PTH analogs, right? That's a X. Clearly decompensated. You can see a pelvic tilt, totally anteverted. That's how she's standing, trying to maintain her balance. Clearly a flat back, creating issues over time. And this is both coronally and sagittally decompensated in terms of where she is. Coronally, you can argue she's there, but it's only a back pain that's getting her. That's a quick view of her lumbar spine. You can see the deformity there and what's going on. And there's an MRI, multiple level stenosis, prior laminectomy with a pseudomeningocele, and which I don't want to ever get back into. And you see stenosis in multiple levels with obviously that defect. And here's a CT scan. The reason was our protocol is very clear: X-rays, MRI, CT scan, bone density. I won't do it otherwise. And you can see hypertrophic, atrophic pedicles, if you will. But more important is no fusion at the other levels. So you can tackle those levels. And here's our overall where we are and what we got. A thoracic kyphosis is 10 degrees. At the best comes to 15. Clearly, highly decompensated, forcing herself to stand straight with anteverted pelvis, creating the back pain she's got. And this is what we've done for years, right? For decades, 2 decades at least. All we've done is posterior surgery because we think, and that's what we've been taught, we do osteotomies in the back and correct this. I got nothing against it. But can we think different? And that's what MIS strategies and all our protocols have taught us, a significant understanding of adult deformity. Dr. Unnikrishnan said that these patients come for pain. They do not come for deformity. They lived with deformity for 70 years. They're very happy. Whether it be adult idiopathic or degenerative, they're fine. They're 60, 70, 80, 90-year-old. We're not talking of 20-year-old. We're not talking 18, 20-year-old. We're talking of the elderly patient who lived with deformity that we are now treating. The deformity is not the problem. They're coming to you for pain. And that's what we're treating. And I think that's really important. We get carried away by the X. That's first point. That's what we're treating. A degenerative lumbar spine, whether it be adult idiopathic or de novo scoliosis, that is the issue every single time. So the big wheel is the disc. The disc is the problem creating the issue. It's not the facet. It's a disc that's collapsing, creating further collapse, creating further deformity, making them collapse to one side, creating coronal and sagittal imbalance. They were not imbalanced with a 39, 40-degree adult idiopathic scoliosis. They lived a life, had 3 kids, they're athletes, they're gymnasts, they've been Hollywood celebrities. They never had a problem. The problem comes much later because of a degenerated spine. So I think that's an important concept we've sort of forgotten to remember. So why not release the disc? The disc is the problem. Why are we doing the facet? If you release the disc and bring the disc back to where they were when they were 20 years old, you automatically balance them out and you took care of their pain. It's a very big conceptual change that I think we need to realize. And that's been the basis of my 25 years of work of where we need to get to. The problem was this: ALIF was hard. It's very hard to do ALIF at multiple levels. Clearly, 1, 2, and 2, 3 are much harder than 3, 4. And all the other problems, the ALIF we know. But what changes this? Minimally invasive lateral, whether you do transverse or pre-psoas, is a massive manipulator of the anterior column. That's the key. We're now able to minimally invasively manipulate the anterior column to get the correction and create ligamentotaxic correction without a single posterior column osteotomy or facet release. And we've been doing this for 20 years now. Not one patient of mine has had a single facet release ever. I think you've seen enough patients so far over my years. The analogy is crumpled tube socket blocks. If you straighten the sock out, the blocks have to line up, which means you recreate the disc height. The spine will line up. That's what the patient had 50 years ago. They collapsed today because of a degenerated spine. It's called the Willis sequence of degeneration, the triad. We forgot all that. These were asymptomatic patients 40 years ago. So we have a protocol that's staged. We do the anterior first, 4 or more levels, and then do the posterior 3 days later. You can see that it's all laterals. Pre-service is what I choose to do. Posterior screws later. The staging is phenomenal. 2 short surgeries of 3 hours each is significant in these patients, as opposed to an 8-10-hour surgery in an 80-year-old. And you're also able to see indirect decompression when they get up and walk. And you can fine-tune that alignment many a time just by looking at the intervening X-ray. So it's been significant in the way we've started this. The pre-service approach to me is like literally an ACDF for lumbar spine. There's a clean corridor between the aorta and the psoas, very similar to what we do every single day between the tracheoesophagus and the carotid. If you measure the distance, you'll never do an ACDF in your life. You're 2 millimeters away. But we create the plane surgically and we go down. The same thing with the pre-cervix approach. The approach is totally determined by the bifurcation. If it's not bifurcated, lateral to the aorta. If it's bifurcated, in the bifurcation, a lateral ALIF or a supine ALIF if you want. Everything's by the bifurcation. It's got nothing to do with crest or the psoas because the embryologically exactly the same. They move together. So you go in the bifurcation ALIF or you go lateral, do your laterals. And that's how we approach anterior, single position. Every single lumbar level can be attacked in this manner. And you can go on. Quick videos just to go through that. I'll scroll through it quickly. That's just the approach for 5-1. Go down retroperitoneal, get down there. And the first thing you do is protect the ureter. It's right there. You know where it is. And then it's a straightforward ALIF approach, but in the lateral position. Protect the vessel, 3 retractors, one on the left internal iliac, common iliac, sorry, one on the bifurcation, one on the right common iliac, and you're literally staring at the disc, just like you would do an ALIF any day. After this, it's a regular ALIF. I don't even use any fancy instruments. The same ALIF we use supine, I use lateral. There's nothing fancy. It's an older video. I don't even use any of this now. It's just you reorient yourself to do an ALIF in the lateral position, clean it out, do your ALIF, and put your device in. Whatever device you put, I really don't care what device you put in. It's a spacer. The key is creating the lordosis. And I don't use these plates anymore. I use integrated antibody devices today to fix it up. If you were doing 2, 3, 3, 4, 4, 5, here again is an approach to the same thing, right? You create the approach down, you go down to the external oblique. The bovie is just to the fascia. But do not use any bovie, no speculums, no metsobombs, no scissors, no knives. A general surgeon does not use a medicine bomb. They do not use your fingers. A finger is really useful. A finger will not tear anything unless you're going to pull on it inadvertently. You're not going to disturb anything. A finger is a beautiful dissector. Go to the external oblique, internal oblique, get down to your retroperitoneal space. I've always said, people ask, how do you know in the retroperitoneal space? And I'm sorry, I've said this many, many times. It's like porn. You cannot describe it. You know you're there. You know you're in the retroperitoneal space. You know when you're in there, and that's how it is. And you know you're there, clean it out, mobilize it, feel the psoas. You can get right in front of the psoas, and that's just a surgical technique. Put your retractor over your finger that has the peritoneum behind you. First retractor. Second retractor goes over the psoas. I think it's a mistake to retract the psoas. The whole idea is to preserve the soft tissue. Go above it. You see the psoas, you clean the plane in front of the psoas. You use peanuts, sponge sticks, you can see it right in front of the psoas. You can see things. All you're worried right now is nothing is in your plane in a transverse way. Drop your first probe, you're in there, take an x-ray, you know where you are, and you're at the disc of target. Put your dilators in, you're looking at this. You can see the psoas clearly in the back with the genitofemoral nerve sitting right there. I don't know how people do trans-psoas and not get that every single day. We just get lucky. It's sitting right on the psoas, especially at 4-5. So drop your retractor down. And once you've done that, I like to see the ALR. You're right there. I like to see the ALR because you want your prosthesis just behind the ALR to get the maximum lordosis. We've shown that time and time again. That's what gets lordosis. So your annulotomy is just behind the ALR. ALR has clear transverse fibers. You will see it distinct from the disc when you're down there. And you create annulotomy right there, drop your carb. At this point, it's like any other fusion, except you're approaching obliquely. So you have to orthogonalize or straighten your instruments. And you're going to see that. I'm taking an x-ray right now to make sure my sagittal orientation is right and I'm not hitting the end plate. You want to be careful you don't violate the end plate. That's what that is. And at this point, you're just basically going down. See, that's become straight now. Now I'm going straight down. Everything is starting oblique and then going straight. And that's how fast I operate, by the way. So it goes right down there. And so you drop your prosthesis, you clean it up, create it. But each time I'm looking at the ALR, I know I'm right behind it. It's highly visual, like how surgery should be. We see what we're doing. create the space, put your prosthesis in, and whatever prosthesis you put. This is a montage of the X-rays. Someone mentioned it, and I think Dr. Unnikrishnan again. To me, an anterior procedure is release, 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 mobilize, mobilize, mobilize. I don't care what the hell you put in there. What prosthesis you put in there is immaterial. It's a spacer. At the end of the day, that opens up the disc space to give you the correction you need. And by placing it anteriorly, you will get good lordosis. And you want to see the end plate move at every single level. Then you know you released it. And preserve the end plate. Be very cognizant of what you're doing. Yes, it's technical, but if you're careful with these things, you can move that spine level by level by level, starting from the bottom up and move it and get the correction you need. And this is right after the anterior procedure. So you already got some correction. Is the intervening X-ray now after the anterior, right? You can see the thoracic kyphosis moved a bit, but not a lot. Came to about 12. You're seeing PLL mismatch getting a lot better from 40 to 20. So we got significant lordosis already in the lumbar spine. And the thoracic, she's still kind of compensating, trying to stay there. She's standing and walking. They're walking that day. I get them up walking that day, occasionally next day. And they do very well after a lateral procedure. So you really know where you are. Then you do the rod contouring, passage reduction, rotation, translation, all the stuff that's really important. I won't talk about it today. And that we do navigation, robotic assisted, and takes about an hour and a half. And that's a different talk. All this is totally step by step nailed down in the simpler technique. We call it the simpler technique. The segmental interbody, muscle preserving, ligamentotaxic enabled reduction. There's not a single osteotomy creating ligamentotaxic reduction, which allows for patient-specific correction of the alignment. And that's a journal. Every single step is in there. Anyone's interested, look at it. So that is the X-ray after the posterior. If you can see there, after the posterior reduction. So you can see where that is. I think I just lost my slide. Hold on. Anyway, so that's after. I don't know what I did. I lost my own slide here. Interesting. Okay, let me get back there. Sorry about that. Oops. I don't know why I lost my own slide, but I can't see it. Anyway, I do. Are you guys seeing my slide?
No, sir.
Yes.
It's going black, sir. Yeah. We cannot see anything. It's only black screen, sir.
I agree. I'm not sure why that happened.
Okay. Can you close it up first and open again, sir?
I can do that. I'll leave the meeting if I do that.
Oh, no. Yeah, we have it now, sir. We have it now.
You have it? Okay,
Yes.
so you guys can see. Anyway, what I was going to say, that I can't see it, so I have no idea what the hell I'm talking about. But anyway, I wish I can see what I'm talking about. Anyway, what I was going to say, basically, if you do these anteriors, right, you're going to see X-rays of patients that we follow down the line, and you can see the intervening X-ray that staging, what staging does. And you can see what staging allows us to see what the interbody has done and what's happening to the thoracic spine. And we're seeing an unwinding of the thoracic spine as we go along. It unwinds itself. And this came to the realization then, why are we treating the thoracic spine? That is not symptomatic. As long as you got back to Dr. Kim, you got global and coronal sagittal balance. It's a lumbar spine that's hurting. By putting the interbodies, we can recorrect this. I'm assuming you're seeing the patient with severe deformity now, who has massive double deformity, but we completely ignored the thoracic spine to where we are and got to where we are at this point. And so you can treat these patients by correcting their deformity and just treating and selectively treating the thoracolumbar area and leaving it and not do a T2 to pelvis. These patients are really happy. Back again, they come for pain. They lived with this deformity year long, years and years. They want the pain to be taken care of. And when you coronally sagitally balance them, they get to where they are. Can you guys see the slides?
Yes, the three X-rays, yeah, sir. Apologize,
Okay.
the time is limited, sir.
All right. So anyway, that's what I wanted to say. Well, basically, by doing anterior, I think you're able, and treating the disc and controlling the disc, you're able to go anterior to correct the deformity without doing anything else. And we have to revise our thinking of what we are doing and stay on the anterior column. It's time we revisited the anterior column, which we've forgotten for more than 2 years. Anyway, a plug for SMIS. I don't know if you can see it. The meeting's coming up soon. I love all you guys who attended. Thank you.
Thank you very much, Prof. Neel. We have, if there are any questions from the faculties, professors?
Neel, I saw your fixation. You
Professor
don't
Niraj,
use
please.
4-rod constructs.
Say that again?
Do you use 4-rod constructs at the base?
Never in my life. 25 years, 5.5 titanium 2 rods. Hardware failure rate is 2.2%, which has been published. And the only hardware that failed was when we bent the rod into the iliac screw. So it broke below S1, and 5.1 was already healed. 7 breakages, 4 of them asymptomatic, incidentally seen on CT scan, which I get at 18 months all the time. There's so many factors here. There's no in situ bending, never. They all stay coronal. It's a graduated reduction posteriorly. They have interbody support anteriorly. The muscles are protected. Think about open surgery. You stripped every muscle, there's nothing there. You did osteotomies at every level, you destabilized it. And now you put a rod. The only thing holding you is your rod. No wonder you need 2, 4, 6, 8 rods now. And you go from 5.5, 6.5, 6.25, keep on chasing the 2. How many rods are we going to put? We've gotten to point of illogic. I'm sorry, I've been strong about this, and yes, people don't like it. But we got 25 years to show now. It's making no sense. We got to rethink what we're doing. And I think we need to get back to the anterior column, which was actually very popular in the 80s and 90s. It changed in the last 2 decades. And it's something we need to think about. And MIS lateral has allowed us access to the anterior column as opposed to the old ALIF. That's what's changed.
Thank you,
Thank
Neel.
you very much. Thank you very much. Yeah. Any other question? Maybe how do you improve the fusion, Prof? The last question, Prof. How do you improve the fusion? You have to, you don't do posterior fusion.
Okay, no, we do. That's an important point. Every patient has BMP in the interbody. So that's an important point. There's 3 milligrams of BMP per interbody space in each interbody device. The levels that don't have the interbody get a posterior pars facet pars fusion, where you just denude the pars facet pars and 1 milligram of BMP per pars facet pars complex. That's allowed us close to a 99% fusion result. So we don't use BMP, you're gonna have to probably accept an 8 to 10% non-union rate. Our non-union rate's about 2%, which overall we've seen so far is extremely low. So the answer is yes, we got to get to perfection. That's all.
Yeah. One more question from Professor Niraj. Yes, sir. Please.
Dr. Neel, as usual, amazing presentation. Thank you for it. One question, what I have observed in my cases while doing this multi-level anterior, specifically at upper lumbar level, sometimes this lordotic cages, they may give slightly extra lordosis than what is desired at upper lumbar level. So how do you look at it in terms of lordosis distribution across the lumbar spine or inflection point? How do you keep this point in mind while deciding what lordotic angle, what cage, how much release you want to do? 1, 2, 2, 3, 3, 2, 3, 3, 4L, 1, 2. How do you plan that part?
Really simple. 4 to 1 should be 40 degrees. 5 1 should be 20, 25 degrees. 4 5 should be 15, 20 degrees. 4 to 1, always 40. So I will do an 18-degree lordotic cage at 5 1. It gives me 20, 25 degrees. It's 12 degrees everywhere. You put a 12-degree cage anteriorly at 4 5, you will get 15 to 20 degrees. 12 degrees at 3 4, you'll get 12 degrees. We've shown that per level. At 2 3, again 12 degrees, you'll get about 10 degrees. It changes at 2 3. At 1 2, I'll put a 6-degree cage. You can do 0 or 1 or a 6-degree cage at 1 2. And that just creates a harmonious spine, which is similar to what a normal human being has at 20, 25 years of age. That's what we're trying to get. That's what that patient had when they were 20 or 25. We're looking at them at 70. It collapsed. They are a normal spine.
Thank you,
Professor Neel,
Professor.
one last question from Professor Tao. Do you mix that, the BMP? Do you mix with hydroxyapatite or not? Last question.
No, the BMP with, I use Grafton, DBM, and Grafton and BMPs work synergistically very well. You can use any DBM. I don't use hydroxyapatite. Calcium silicate works very badly with BMP, so I would advise do not use it. I do not know what hydroxyapatite and BMP. BMP is very specific. It works good with the DBM. So you want a BMP and DBM, that's fine. And yes, I will do that. And just to add it, but I think it's really BMP doing the job, honestly.
Thank you very much, Professor Neel. Again, with the interest of the time, I give the time back to Professor Ajay Shetty for the last session, sir. Thank you very much, Professor Neel.
Thank you.
Dr. Alia?
Yeah, okay, thank you for the last session. We'll be talking about proximal junctional kyphosis, the unsolved problem from Dr. Amit Jhala. He's highly renowned senior consultant spine surgeon based in Ahmedabad, India, with over 30 years of medical experience. Professor Ahmed, the time is yours.
Okay, thank you. I am the last player of the webinar. And you have seen right from the beginning that Ranjith planned everything. Dr. Franke went up to the SI joint, and Neel did the anterior surgeries. But at the end of the day, whatever we do, we have to face, or the surgeons have to face, the proximal junctional kyphosis, and that's an unsolved problem. We give the best alignments, but still we have proximal junctional kyphosis, and it's a surgeon's nightmare. Because you have done all the hard work to get the alignment, and at the end of the day, if you get a proximal junctional kyphosis, not only the patient, but also the surgeons, both are also in the problem. And definitely, it's an unsolved problem. There are a lot of papers and decades of research, and maximum number of papers are published on adult spinal deformity. But still, the incidence of mechanical complications are high, as on today. The incidence is around 20 to 40% of PJK and around 15% for the PJF, but the neurological deficit rate is around 6.2%. And it is leading cause of revision surgeries in adult spinal deformity, with significant deterioration in health-related quality of life, and it's a huge socioeconomic burden to the healthcare. Now, I'm not going to these minor details of PJK and what is a PJF. And there are different definitions for the PJK and PJF. Everyone knows it. But this is very important that it can fail either at the soft tissue level, or it can fail either at the bone level, or there can be an implant bone construct failure. So this is how the failure can occur. If it is a soft tissue or ligamentous failure, you can observe, and the patient may have a little bit of back pain, but still the patient can be treated conservatively. But if it's a bone or implant bone construct failure, definitely you will have to go again and do neurosurgeries. Now I'm taking everyone back to before the era of understanding of the sagittal alignment. And this is in 2007. We had this patient who had an L3-4, L4-5 stenosis, and somebody did a laminectomy in 2007. The patient came back within 6 months. The patient came back within 6 months, and there was a listhesis, and there was a recurrence of the herniation, and then it was fused. And you can see that this was a Moss Miami construct way back in 2007. And you can see it's a straight spine, and there was no concept of contouring. And then patient again developed after 3 years. The patient had the PJ or the adjacent segment problem and the patient went a third surgery. This was just an extension of the fusion, because to get a good alignment at the lower level, you will have to do an osteotomy. And that's why everyone just goes above with an extension and extension. 5 years post-op this surgery, again, the patient had an adjacent segment problem. And again, an extension of the instrumentation was done. And again, the patient got the PJK. And this is 5 years after the fourth surgery. Again, patient came with a neurological deficit. And you can see now the whole spine has been totally flattened. And now this is a real problem where you have to manage this patient. And with all these parameters, with only a thoracic kyphosis of 5.5, 18 degrees of lordosis, and with a high PI, you have to correct this. And there's no other way except doing an osteotomy. And we planned an osteotomy with the software, and this PJK was dealt with by going right up to the proximal thoracic region, and did a PSO at a lower level where there was a fusion. And this patient then stabilized as on today with after 6 surgeries that patient underwent. And that's a 4-year follow-up after the correction of the deformity. So PJK, EPJK, and PJK, that's going to be there if you don't follow the standard principles, and if you don't respect the sagittal parameters, even if doing a single level fusion. And that's very important. And extending the fixation is multiplying the problems rather than treating the problems. So this is very important, that whenever you're doing these surgeries, you have to look at the sagittal parameters, and they are very important part. But this case was done as way back in 2007. So the risk factors for the PJK are multifactorial, and there are a lot of factors. There are patient factors, and the most important patient factors that we have is an old age, because all these patients are old age. They have an osteoporosis. They are sometimes obese. You have to check the frailty index. And these patients with an osteoporosis and old age, they have a sarcopenia with a paraspinal muscle quality, which is quite less. And these factors are very important in producing the PJK. So it's not only the alignment goals that we are looking at, but we have to look at the whole patient profile. And then some factors which are very important, and which I'm going to discuss it now, are the radiological alignment goals. And we have to define the alignment goals and plan the surgery accordingly. And what we have achieved is also very important after that. And depending on the alignment goals, we need to have our surgical construct and the technique that we use. What is the fusion length? What would be the upper instrumented level? What would be the construct of the UIV, whether it will be soft landing or whether it will be screw construct? You should have what type of rod contouring. You should have an implant construct, high density, low density, whether you do an MIS, an open, and a very beautiful lecture by Neel, whether to do an anterior correction or an osteotomy. All has to be planned before, and depending on each and every individual patient. So it's a multifactorial problem that we are looking at in this patient. The only thing is that this is not in the surgeon's hand. We cannot, whatever the patient we get, we have to treat it, and that's not in our control. But actually, the radiological alignment and the surgical construct and technique on which we can work to prevent these PJK. And that's very important, and that's what we can do to reduce the rates of PJK. Now, this is just an example of how osteoporosis can affect, and it's very important to treat the osteoporosis beforehand. So this is a patient had an L3 fracture, and the patient was treated with a vertebroplasty and fixation, because there was already a stenosis lower level. So surgeon we went actually lower down, but it was an overcorrection that we had. And what happened is that it was quite obvious that after 1.5 months or 1.5 months, the patient developed a proximal junctional failure, and the patient came back with a paraparesis. And then we did all the things what was required. We stopped at D12. We had a discussion with the patient whether to go right up or up to D10, and the patient did not want to go up to the proximal thoracic, considering the morbidity this patient was having of surgery. So we stopped at D10, but we augmented the screws. We did a prophylactic vertebroplasty at D9, but nothing helped. The patient again came back after 5 months, and then we had to go right up to T3. We also did all the things which were possible, which were needed, like cemented augmented screws at all the levels, gave a very nice contour, and upper instrumented vertebra was D3. But still, the patient had a D3 with a complete paraplegia. So that was 7 months post of the third surgery. So osteoporosis is definitely a big problem whether you go there. And then we had to go right up to the C7, and we stopped at C7. Again, this time also we had a discussion whether you want to go right up to C2 or not, but we just stopped at C7. You can see that gradually the tower will build up, and the osteoporosis is a big problem. So the question is, osteoporosis is a major risk factor which you have to look for in proximal junctional kyphosis. UIV should be at the proximal thoracic level, and UIV should be at the proximal thoracic level in osteoporosis, and that's very, very important. And the patient started walking after the paraplegia. Another patient, and this is where we learned from the previous case, and this was again an osteoporotic patient, had a vertebroplasty, failure of the vertebroplasty, did a nice correction, but then there was a PJK again, and this patient, we directly went up to T3, and the patient is doing absolutely fine. So this is very important question that need to augment the screws and better to stop in upper thoracic region rather than lower thoracic region in the patient with an osteoporosis. So regarding this, the patient profile, osteoporosis is one of the major problems that we have, major issues that we are facing in these kind of the patients. The second thing what we are facing is in alignment goals. And have we solved the alignment goals? And that's a very, very important part that we have. We all started with a golden figure of PILL mismatch of less than 10 by SRS Schwab in 2005. But I think this was just the beginning of the problem. So
Hello, Professor Amit. Apologies, I think we lost him.
Yeah, I think
Dr.
we
Aulia?
lost him. Let me try to talk to him, call him. He might not know.
Apologize, everyone. We will try to clear
So
the technical issues.
we can take some questions or
Questions, yeah?
discussion.
Okay, I think Professor Neel, you are answering Professor Tao to chat. Can you describe your Professor Amit is here. Professor Amit, you can continue, Prof. We just lost you, Prof. Okay, and you're still on mute, sir. You're still on mute, sir. Sorry.
okay, you can see my slides.
Not yet, sir. You should reshare
Not
it.
yet.
Okay, I'll share it again. Okay.
Yeah, we can.
Okay. So then the main question again was, what was wrong with the SRS Schwab classification? And the main problem, it did not include age and the PI in the goals. So by adding these age and the PI in the target that we want, whether it improved or not. So targets for ASD should also vary by age and PI. And therefore, these charts were given whether you have to have a specific PI and age matched alignment goals. And this is what can help, whether it can help in reducing the PJK rates. But what happened is that even after matching with this, we had a lost in one of the important factors, and Professor Rasoli came out with the importance of the lordosis distribution and lumbar apex with the inflection point. And then he says that not only this age, PI, everything is important, but you should also look at the lordosis distribution index and the lumbar apex where it is. And then came the important that if you have these matched Rasoli types, then you can have a 72% of the patient not matching the ideal. They suffered a mechanical complication, but only 15% who matched did not have this mechanical complication. And they said that Rasoli matching is not restoring the proper ideal Rasoli type is very, very important. And then ESSG group, the next step to restore the ideal alignment goals. And then ESSG group came with this gap score. And we all know about the gap score, that they not only included the PI, they also included the age, and they gave the PI-based individualized scoring system for decreasing the mechanical complication. And that was supposed to be very, very important because they reduced the mechanical complication rate in their studies to about 6%, where it was not matched or not proportional. Then it went up to 47%. And that was the big way forwards. in matching in 2017. But whether this was validated, and therefore the validation of the gap score was done by, one is an IASSG group and other was an Asian group. And in both these validation groups, the gap score did not validate that these alignment goals, that if you have a gap score matched or proportionate, that was still not validated. And these still patients had the problems. So where is the problem? So problem is not only in the alignment goals, as I said, you should consider the physiological age, the bone quality, other joints, and then came the dynamic parameters, and then came the concept of body balance rather than the spinal balance. So you just not look at the lumbar or a pelvis or the thoracic, but you have to look at the whole body balance, including the lower limbs and the hips. The other important problem that we are facing is the per-operative reproducibility. Whatever we plan, whether we are able to reproduce per-operatively or not. And looking to all these factors, this is the paper which came in 2024, and they gave a new alignment targets. And the most important target is the L1PA and T4L1PA axis. So if you match this T4 hip axis, then the chances of getting the mechanical complications were very, very less. And this is a new alignment goal that we are working on it. So what is the importance of this? Because deviations from these targets in either direction, like means if you have an overcorrection at T4L1PI axis or an undercorrection, this is independent of age. So now you don't have to consider the age as one of the factor because it works for any age. It also works whether you have a good lordosis or not. So because it works for both the magnitude as well as the lordosis distribution. And this is what was from their paper, which was there. So it is the first target built from the healthy population. It captures the shape, not only the magnitude of the curve. Every point in the axis is directly modifiable intraoperatively because you can preoperatively plan, and wherever you want that if this axis is not matching, you can correct it intraoperatively. It links the proximal thoracic as well as the distal alignment, and it extends to the cervical compensation also with this C2 hip axis. So it probably is a new, probably was a new alignment goals. But still in that paper, if you see the mechanical failure rate is around 28.5%. So whether we have still reached to whatever we want, I still doubt about it. And the validation of this T4 hip axis was done again by the another center of Munish Gupta. And they say that as T4L1 hip axis is definitely the better axis, a better parameter compared to L1 PI angle. So if you have this axis, and that's a new parameter that we have to follow. So considering this, you see this is another case that we had. That patient came back with a severe sagittal malalignment. And you can see that we corrected it and we could match the whole T4 L1 PI axis. And this patient was doing very, very well just by this axis which was matched. But as opposed, that's the correction that the patient had with this. As opposed, this was another patient who had an L34, L45 fusion, and this did not match. And when this did not match, this patient again came with a proximal junctional failure. You can see that that's a peroperative picture. You can see there was a fracture just above the instrumented area. So this was an overcorrection, and overcorrection is one of the biggest problem that we can have in PJK. And then we extended, in this the same patient, we extended the fusion to level above. But after that also, this patient had a similar problem, which was we did not correct the lower fused area. And the 3 months post-op patient again came with the PJK, and then we had to again go and extend it above. So this, I don't think that we have reached completely to our alignment goals, and we have to keep our fingers crossed because these results are only for 2 years, and we have to wait for minimum 5 years to get whether it is possible or not. The important other aspect is to protect the proximal segments while the dissection, and you can use so many other strategies of segment augmentation, semi-rigid fixations. But how much they help in preventing, that is also doubtful because there are no robust studies to have this. So we have just got one puzzle, a lot of puzzles to be solved. And what remains genuinely unsolved is no prevention technique reliably eliminates the risk across the patient population. Still, it is a big problem. There are no RCT has directly randomized major prevention strategies against each other's. The bone quality, the muscle quality, the alignment are rarely optimized together in the one flow, and the planned correction is achieved in minority of the complex cases, an execution problem, not just a design problem. So it's a big problem that we have is an execution. So we have got one thing with us is a planning. And the take home is it's a multifactorial in nature. Targets are getting better, but execution is definitely a problem. Whatever we plan, but we are not able to 100% execute. And that's a big way forward to look at to prevent this proximal junctional kyphosis. Thank you very much.
Thank you, Professor. Is there any question from the audience or from the faculty?
Yeah.
Amit, regarding gap score, I can tell you that the gap score did not validate anywhere. Our old series, MIS, was not validated. We published it. Larry published his open series and not validated. So I think the gap score is a big issue. It did not validate in most studies. But one thing I think we learned is the lordosis distribution. That 4-to-1 lordosis is really important. And that I think we know today. It doesn't matter what Rasuli type. 4-to-1 is 40 degrees, period. All that changes the inflection point. High PI, apex is L3. Lower PI, apex is for 4 and 5. That's about it. That's the simplest thing to remember for anyone. That's it.
So, Neel, can I ask a question? What about
Sure.
you must have evaluated this T4 L1 PI axis. So whether
like
it's still working with a long-term follow-up or not?
It is. I think it makes a lot of sense. Like there are three things that make a lot of sense. I like L1 PA where you can see it in the operating room. L1 PA you can do on a lumbar X-ray in the OR, right? You can see that. T4 L1 PA is good if you got thoracic kyphosis. So you can correct that. That's good if you're going to T2, if you're doing that. But I think even better is a C2 PA or C2 tilt. That's the same as your center of cranium over the hip. I always say put the head over the hips. Forget the SVA. The SVA is so wrong, we got to forget it. You put the head over the hip, you're fine. What's in between doesn't matter at all. Patients are really happy as long as the head is over the hips. So that's the same as a C2 tilt. C2 tilt corresponds to that. And so that's the only other thing to look at.
But they say that this parameter also takes care of C2 to pelvis.
It does. If your L1 PA, T4 PA mismatch is within -3 to 4 degrees,
yes,
your C2 tilt will also match.
That will
unless
also
you got specific cervical deformity. Now you are now the cervical deformity, that'll change. That's all. That's the only thing it takes into account. C2 tilt the cervical deformity. And that is fine.
Right.
Agreed.
Actually, to both of you, I mean, isn't T4 L1 hip? Isn't it a little bit of a kind of a short form of the Rusuli types? A little bit, it seems to me, and actually, I fully agree with you, Neel. So though you have to get the apex of the lordosis right, but also, and this is probably one of the reasons of PJK, you have to have the inflection point for that specific type from the lumbar lordosis to the thoracic kyphosis somehow right. And this is kind of most of the time is if it's fine, if the thoracolumbar junction is kind of flexible, you might get away with even a short fusion in the lumbar spine. But if you go into the thoracolumbar region, I think you should not only look at the apex, but also at the inflection point. Would you agree, both?
No, 100% agree. The problem is the way we're doing it, right? I'm going to go back to open posterior surgery. We're doing multiple osteotomies. You can put that spine wherever you want. So the bend of the rod becomes so critical. So this aspect becomes paramount of everything we're discussing if you're doing open posterior osteotomies. If you flip that into anterior interbodies, it's irrelevant because all you're doing is recreating the disc space the patient had before. The patient lines himself up. You get soft tissue realignment that literally is turning to be patient specific for that patient. It lines up. But that's how they were when they were 20 years old. They were not imbalanced. They're 25 and 30. They got imbalance later. So all we're doing is putting the disc back up. So a lot of this discussion is actually mute when you do anterior interbodies, as in laterals, by not even taking the ALL out. If you did A-lifts, again it'll matter because you're going to put hyperlordotic cages and throw it off. But you're not doing an A-lift, so ALL is intact. So you cannot overcorrect with the lateral. I've said it forever. You can undercorrect, yes. If you don't do a good job, you'll undercorrect. You cannot overcorrect. It's a very different paradigm. But posterior, I agree with you. If you're doing posterior, absolutely matters what the inflection point is and Rasuli. But I think eventually if you line up T4PA and L1PA overall, like we just getting a paper out, even our PJK over time, if T4P and L1PA did not line up, yes, they slowly started getting some sort of PJF, PJK. It's best to line that up.
But
No
what
question.
about in
One more
those,
question, Dr. Neel. Whether these patient-specific rods, they will help or not? Because that's where the main point is going to be. Because how rod you are contouring, the spine is going to take the same alignment.
I mean, 100%. Do I need that? I can bend a rod any day, right? And so can you. Most of us who have bent rods all our life can bend a rod any single day. But I think what's happening is helping the younger surgeon because now you have a template to where to go to, and all they got a little tweak here or there. So I think that's the only place. It's nothing great. The patient-specific rod is giving you a template on the table to know where to go to. So all you do is a little bit here, a little bit there, and you're done. As opposed to a young guy who's struggling to know what to bend. I think those of us who have bent rods, I could close my eyes and bend a rod, right? We've all done that. So the answer is for me personally, no, but I love it because I personally love it because of the data. Now they are measuring my x-rays and it's not me anymore. I love it. So nobody can say I'm doing it now. They got all the data now, they're measuring it. So I got a third party looking at it. That's honestly the reason why I got it. So they got all the data. So it's great. I like it.
But Neel, you shouldn't forget the fact, before you have the rod bent by, the machine, right? The younger guys have to sit, on the screen and make a good plan and, think about it. And that's pretty good in addition to the template. Once you are in the OR and your rod goes in like with no pressure at all, you're fine. But on the other hand, actually you executed the right plan, and to make the plan is a good learning experience for me.
I think it's sad they're not learning to bend. I think you have to learn to bend. I remember Dr. Bawachi, we should literally learn to bend these rods. Bending the rod is an art.
Yeah,
Nobody does that anymore. It's an art.
But we in Europe we do that because we have a little other pricing thing going on than in the US. That's the same with the BMP. I would love to use BMP in any antibody, but
well, hopefully the patent is out, so hopefully there'll be enough BMPs coming out. That's the hope now, right? The patent has been released, so hopefully generic BMP will come for everybody. No, I'll openly admit it's a game changer. I would not have got the results I got if I didn't have BMP. I'll very openly admit it. There's no question, right? It's a very big part of what we've done, especially MIS. I completely agree. Hopefully it'll be there.
I have one question. When while measuring all these angles, to Dr. Neel, to Dr. Amit Jhala, to Dr. Franke, the L4 hip angle, what you mentioned, what if your thoracic spine is stiff? Because we are measuring only the mobile spine. What if in that particular patient a thoracic spine is rigid, stiff, and maybe it's not the ideal curvature as per the lumbar lordosis. So how do you decide whether you want to go up to T2 despite having your T4 angle fine, or how do you think about that?
I mean, before, right? You're going to make a decision. Okay, again, it depends what you're doing. If you're doing posterior, you're buying a T2 to pelvis on day one if your thoracic spine is stiff. It's not going to come around. But we're doing the way I'm doing it with laterals and staging it. I can do lateral interbodies, take an intervening x-ray, and see where the thoracic spine lay. In fact, in our paper, when we published, they would not let me publish it without saying that. So we actually put it in that after the lateral interbodies, if the thoracic kyphosis is greater than 60 degrees, only then you need to go to T2. And I promise you, Neera, to this day, I've not seen a patient with a thoracic kyphosis greater than 60 after the lateral interbody. It's unwinding itself, including thoracolumbar kyphosis. So it's a very different way of treating it. If you're doing posterior, you're going to go TT. They have no other choice because you don't have the lordosis from the front. It's thinking differently. You have to think differently. So what we're doing is really radically different and regaining the anterior column, which unfortunately we have lost. When I was in England, we did anterior all the time. Like we completely changed how we came back. Anyway.
So, Professor Kwan, I guess Dr. Ajay and Dr. Professor Kwan, concluding.
Yes. Okay. I think that we have come to end of this webinar. I would like to say thank you for the excellent session, great discussion, great information, great talk. No doubt, I have to say specifically thanks to Dr. Rajesh, Dr. Tao, Dr. Franke, Professor Luke, Professor Neel, Anand, and Dr. Amit for the excellent talk. I think not only the talk, the discussion part, which is very informative and very beneficial for all the audience here. I also take this opportunity to thank the online education committee, the chairman, Niraj, you did a very good job. I think this is a very excellent adult deformity session, very beneficial for people, members around in the Asia Pacific region. And lastly, thanks to Ortho TV as well as our APSS Secretariat for all the hard work to make this webinar a successful event. Thank you very much, everyone, and have a good weekend.
Thank you, everybody. Thank you so much.
Thank you.
Thank you.
Good night.
Thank you so much, sir, for the session.
Thank you so much.
Thank you. Thank you, Doctor.
Thank you, everyone. A great session. Great session. Enjoy.
Thank you. Thank you, sir. Thank you. Thank you.
Now, sir, we are not live, so if you want, you can talk.
Yeah, we can exit. I think everybody would be wanting to go for their Sundays now.
Okay.
Thank you. Thank you. Thank you, everyone. Thank you. Thank you, sir. Thank you so much. Thank you, Dr. Neel, for keeping awake. Thank you so much. Thank you, Professor Franke. Thank you, everyone. Thank you, Kim.